Good afternoon. My name is Bill McCunniff, and this year I have the privilege of serving as the McLennan County Medical Society President. Thank you all for attending our second ever Medical Society membership-wide virtual meeting. Over the next hour, we will be addressing the present state of COVID-19 in our county, along with a number of local factors influencing all aspects of medical care for our patients. COVID-19 continues to have an even greater effect on the way we provide care both today and into the future. Our goals for this meeting are to inform all physicians in McLennan County about our current status, along with providing guidelines for management of these patients and their exposures, which we are all encountering on a daily basis. We want everyone to be informed of our local response and communicate about methods to improve care, consistency and guidance, and inpatient treatment options. As physicians, our patients rely on us to provide accurate guidance, thus we have several physician experts participating in this meeting today. Dr. Mike Harden from the Family Health Center will provide our current updates. Dr. Shaw, the lead epidemiologist from the McLennan County Health District, will provide information about statistics and trends. Then two pulmonary and critical care physicians, Dr. Bert Stewart from Baylor, Scott & White, alongside Dr. Matt Patillo with Ascension Providence, will provide firsthand accounts of ICU status and inpatient critical care treatments and care updates. Additionally, we have Dr. Farley Werner, our County Health Authority and infectious disease specialist, along with Dr. Rod Ritchie, pulmonologist, who will also be available to answer specific questions. We plan to present for about 30 minutes and then leave 30 minutes at the end for questions. So please keep all questions until the end and we will address as many as possible. With that, I'd like to introduce Dr. Mike Harden to begin his portion of our presentation.
Thank you, Dr. McCunniff. I'll start first by telling you what I'm going to tell you an overview, and then we'll move on to the more details here. So in McLennan County, as you guys well know, we've seen a significant increase in the number of cases and test positivity. Our current hospitalization rate suggests that we have a high utilization and it's going to increase in the future if there's not significant changes in our curve. There are local testing issues that we'll talk about. Remember that a result when it's negative does not always mean that someone does not have COVID-19. And for physicians, this still continues to be an uncomfortable paradigm shift. There's a lot of uncertainty. Our test results are not perfect, and our test results really not about the patient in front of us in the outpatient setting, but it's about the community, and you play an important role in that. We'll first review some data. Our new cases per day per 100,000. This is the 7-day moving average, and we do the moving average to account for weekends and other testing abnormalities in terms of data reporting. And if you look, Waco is in the blue, Texas is the orange line, and the US is the gray line. You see at the very beginning, as we showed 6 weeks ago, we started out ahead of the rate of Texas, but then quickly dropped down in terms of our number of new cases. And that was directly due probably to the shelter-in-place order that was placed early here in McLennan County. We continued at a very low rate throughout that time. Phase 1 reopened, then phase 2, and then in June, phase 3. And you can see we started to have an uptake before phase 3, but we really started to take off after phase 3. And we've now clearly crossed, in terms of new cases, crossed the line for the average of Texas and for the nation as a whole. That's not really very good news at all. You can see that typically when you make a change in reopening, it takes 2 to 3 weeks to see that effect on the number of new cases. The same applies if you reverse it. If you start restricting and opening and you improve social distancing, it takes 2 or 3 weeks to see that effect as well. Another test stat we look at is our test positivity in the 7-day average, moving average again on that. Waco and McLennan County is in the blue, Texas in the orange, and US in the gray. Again, we started out ahead of Texas, but then quickly dropped as our cases dropped. And then now you can see as we got to June and June 15th or so, our test positivity increased dramatically. And we are above 15% at this time. And that does not include the 224 new cases that were identified today. So we're certainly even a bit higher than that. We have crossed the line of Texas at this point and definitely ahead of the United States. You may have heard experts say anything above 10% is significant in terms of test positivity. Another misconception out there often is that the more tests that you do, you would expect the positivity to go up, but that is incorrect. As you do more tests, the test positivity should go down in the face of more tests. If the test positivity stays the same, that's not good. And if the test positivity goes up in the face of increased testing, then that's definitely a reflection of increased community spread. This graph I showed 6 to 7 weeks ago at our last seminar, looking at the IHME predictions for hospital bed utilization. The early predictions there in the green line showed that there was going to be a big surge, but those predictions were modified to the red dotted line after social distancing and stay-at-home orders took place. There are new predictions out there by the HME, but I've included just these two for now. Again, the blue line at the bottom is hospitalizations for Waco. The orange is for Texas, and those axes on the left and right are equivalent McLennan County beds, and on the right, Texas beds. And you can see we started out ahead of Texas, but then quickly dropped down, and we were only averaging 1 to 2 patients at a time in the hospital for an extended period of time. But I've added in the recent data here. You can see that Texas continued to track along that prediction as a whole, and then significantly increased, and we began significantly increasing in June as well. You can look at the slope of that curve for McLennan County, and that is certainly much steeper than it is for Texas. It implies that we may cross over Texas sometime soon. And if we were to guesstimate maybe 2 to 3 weeks down the road, if we continued on the same trajectory, maybe we'll be at 100 beds. It's hard to statistically predict that. We don't have the systems or data to be able to run those statistical analysis, but that's just a guess looking at this graph. I'll move on now to testing, and I reviewed this last time, but we'll quickly review a few things. The RNA assays are the nasal swab tests, either the Abbott test or the PCR test. Serologic testing for the antibodies, and then antigen testing, as we mentioned last time, had not been released or invented yet, but now has been released and has been put into use as early as this Monday. We started using it at the Family Health Center. It is like the rapid flu test or rapid strep test. It's run on the same instrument, and those test results are available in about 15 minutes. The PCR or the Abbott test has a sensitivity of somewhere in the 90 to 95% range. We're not exactly certain, as there's not a gold standard test to compare it, so there is a possibility of a false negative with that test. The specificity is nearly 100% since it measures directly genetic material specific to the virus. There is a rare false positive, meaning that though they may have had the virus, they may be in the pre-symptomatic stage, or they may be in the convalescent phase and not have a virus they could transmit at that point, but they have had COVID at some point. Serologic testing, the only thing I'll say about that is it is not recommended for the diagnosis of acute infection. Its sensitivity and specificity are not good enough to make that diagnosis. It is possibly valuable for late assessment in illness in conjunction with viral tests. If, for example, in a hospitalized patient, if you have a negative viral test but highly suspicious later in illness, the antibodies may turn positive and help support your diagnosis. Or for diagnosis support for post-infectious syndromes like the multi-system inflammatory syndrome in children. ELISA testing for research surveillance is actually now going into place here in McLennan County, performed by Baylor and in conjunction with Family Health Center research project. Antigen testing is the new kid on the block. Its sensitivity, we think, is around 81%. Again, that data is not clear yet. Its specificity, just like the PCR test, is nearly 100%. So what do my results mean today in Waco, Texas? When we have increased prevalence going on, we can estimate, just based on our test positivity rate, a pretest probability of 15 to 25%. You can combine that test probability with actually your clinical suspicion as well. This is kind of like flu season. We're in the peak, just like we were in the peak of flu season. You would often diagnose someone with the flu without doing the test because the test may give you a false negative. In this case, you still need to test, and I'll explain why in just a minute. So if you have a high clinical suspicion for someone, let's say they have a headache, shortness of breath, cough, fever, body aches, new loss of taste or smell, you'd say maybe they have an 80% probability of having COVID-19. You have a high clinical suspicion. If you test them with the PCR or the antigen test and that test is positive, then it's a true positive result. Now, if you test them and that test comes back negative, there's a probability that's a false negative result. If you look at the table on the right, using Bayes' theorem, we can calculate the post-test probability with a pretest probability of 80%. And that post-test probability, depending on your test that you use, is anywhere from 18 to 43%, or even greater, that they still have COVID, even though the test was negative. That 43% is for the antigen test, which has a sensitivity of 81%. So in that case, you would possibly, based on your clinical suspicion, make a diagnosis of a COVID-like illness, even though it's not test proven. Now, if someone comes in and they have a low probability of having COVID-19 and they test positive, well, it probably is a true positive too, 99% of the time. They may not be able to transmit the illness at that point, or they may be pre-symptomatic and transmitting at that point, but we don't, they have had COVID for certain. If it's negative, then it is a true negative. There's still a 2 to 4% chance that they could have COVID-19, but likely it's a true negative statistically. So what does this mean for us as physicians? We just have to remember on the outpatient setting, the testing is not about the patient, it is about the community, and that's a paradigm shift for us. The PCR and the antigen test have a very high specificity. We can trust when it's positive that a patient needs to isolate or their contacts need to quarantine. And an important point to make here is that if you know the results are going to be delayed, if there's a 1-day delay or 2-day delay or longer, like 3 or 4 or 5 days as it's gone up to at this point, then it's important to go ahead and appropriately counsel patients on self-isolation while they're waiting for that result. They may even inform some of their contacts that they have a test pending and they're in self-isolation, because they will not be contacted by the health department until that test turns positive. Your best course of action is to continue to test widely for people who have symptoms with a high specificity test, so the nasal swab test. And probably the most important point I'm going to make now is regarding COVID-like illness patients. If you make that diagnosis, that is your clinical decision as a physician. And the most important thing to know is, though your system may report COVID-like illnesses to the health department, those are not tracked or traced by the health department. They only track and do contact tracing on those with positive tests. So in this case, you need to assume the role of the health department and do appropriate counseling on self-isolation and quarantine of contacts if you're diagnosing clinically a COVID-like illness. And Dr. Werner today sent out a very helpful information sheet that went to all the MCMS members. You should get that in your email today to help you with that process. I'll go ahead and stop at this time and take questions at the end, but pass this on now to Vaidehi Shah, who will talk about epidemiology and other factors from the health department.
Hello, everyone. Thank you, Mike, for the introduction. I will be talking about the epidemiology portion. I'll talk to you about what happens to a case once you report a positive to the health department. And then, because of the increase in cases, we're changing some procedures in the health district, and we'll talk more about what kind of isolation instructions we give. So when a positive lab result comes to the health district, what we do is we conduct an epi investigation, which includes collecting demographic information as shown on the slide. We ask them questions about what they did during their incubation period to find out how they may have got the disease. So we ask about history of travel. We ask if they have been exposed to someone who has COVID-19. With the high prevalence in the county that we're seeing right now, these questions are getting less and less relevant because we know there is a lot of community spread. We have seen a lot of cases recently where we're not able to pinpoint a known source of infection. The next part of the investigation includes walking through what they did during their contagious period. Contagious period right now is classified as 48 hours before symptom onset, and if they are not symptomatic, then 48 hours before the date of collection of lab specimens. We ask them what activities they did during that time period, and also who did they come in contact with. This would include household contacts as well as any other non-household contacts, like friends when they went for a gathering or a reception. Did they go for dinner or lunch somewhere? Any kind of workplace contacts. Once we have this information, we provide them with written and verbal isolation instructions, and we provide them with quarantine instructions, and also provide with some community and mental health resources. In the isolation instructions, we ask the cases as well as the household contacts to be isolated until the case meets the discontinuation of isolation criteria for CDC. The next step in our investigation is active monitoring, which is a daily check-in to check with them how they're doing, what kind of symptoms do they have, and if they do get symptomatic, then we ask them to talk to their physicians and get tested. Because of the significant increase in cases, we have reached our capacity to conduct active monitoring at the health district, and that is why all of this active monitoring has been handed over to the State Department, to the Texas Department of State Health Services. Next slide. So what I want to talk to you right now is what happens before we get the test result at the health district. When a person comes to your clinic with symptoms and you decide that this individual needs to be tested for COVID-19, what we request you to do is provide isolation instructions to this person. Dr. Werner released a memo, and in that memo, he has given detailed guidelines and instructions on what we should be providing or what you should be providing to those people who are being tested. So during the time period when they are pending results, they should be isolating at home. We have seen several people during our investigations who say that they did not know they were supposed to isolate during that time because they still did not get a test result, and they have gone to work and they've gone to meet their family and friends, and that is how we've seen an increase in spread in the community. So we request your assistance with that. And then once you get the test results and if they're positive, then the cases as well as their household members should be isolated. These instructions are available in Dr. Werner's memo. It talks about what they should be doing during that isolation period and what is the criteria for discontinuation of that isolation. Once you have given them those instructions and they come to the health district, we will conduct the investigation as I described in the previous slide. The reason why we are asking to add these isolation instructions during your procedures is, one, as you're aware, the lab testing turnaround times have increased a lot. And then from the time when you get the positive lab result to when we conduct the investigation, it may be approximately 48 to 72 hours. And we want to make sure that these people are staying in place and not going around the community spreading the disease during that time. Thank you.
Thank you, Vaidehi. We'll now move to Dr. Robert Stewart and Dr. Matt Patillo to share a little bit more about hospital management and utilization here in Waco.
All right. Thank you so much, Dr. Harden and Dr. McCunnough, for the opportunity to speak to the McLennan County Medical Society. So we're going to talk a little bit about how COVID presents to the hospital and some of the basic hospital treatments that we're offering at this time. So just to put it in a little bit of context for everybody, we are seeing patients present to the hospital anywhere from day 7 to day 14 of the illness from the onset of symptoms. Critical illness is usually being required of patients, and severe illness somewhere between the 10 to 14 day range, but of course it's just a bell curve. We're seeing patients present with severe illness as early as day 3, 4, or 5. So a lot of what we're doing for these patients is supportive care and kind of critical care as usual. They are coming in, as you know, with hypoxic respiratory failure and some progressing rapidly to acute respiratory distress syndrome. We're trying to mitigate the need for mechanical ventilators by using high flow nasal cannula to avoid intubation. We are trying to avoid utilization of non-invasive ventilators such as BiPAPs, CPAPs, out of concern that it causes an increase in the aerosolization of the virus. Also, in an attempt to decrease aerosolization, we're using inhalers instead of nebulizers, and even trying to avoid inhalational medication altogether. However, there is a balance between protecting ourselves and offering the standard of care for our patients, and certainly anybody with COPD or who is in bronchospasm is going to get this treatment. We just may want to position them in the hospital in an isolated room prior to administering nebulized medicine. If they progress to require mechanical ventilation, we're intubating them in a manner to try to avoid coughing. So we're using a rapid sequence intubation. We're covering the heads of patients with plastic sheets and using video laryngoscopy. We're also avoiding bag valve mask utilization during these procedures, which makes the intubation a little more high stakes. However, we're having good success with this protocol. Once on the ventilator, we're going to use a high PEEP strategy based on the ARDSNet protocol and tidal volume of 6 mLs per kg. We are also utilizing early prone positioning as well, and we're finding that basically the lungs of these patients are a little bit unusual compared to the rest of ARDS in that they are very compliant. We're not having difficulty ventilating these patients at all as we normally do in most cases of ARDS. However, oxygenation is severely impaired in most of these patients. And then we'll, of course, do sedation holidays and early mobilization to try to get people off the ventilator as soon as possible. But like with many other viral-induced ARDS syndromes, we're seeing that they're requiring mechanical ventilation for a couple of weeks or more. Matt, do you want to add anything else to this discussion?
A lot of these patients, as you know, don't come off the ventilator. So if they get put on a ventilator, they're going to be there for a while. And so positioning and breathing techniques have really become something that we've tried to implement with the patients. I had a lady who ended up getting intubated, but it was interesting when she was on her back on high flow nasal cannula, she would sat 80 to 82. We would simply have her roll over and get on her stomach and her sats would go to 99%. The problem with her and the reason we could not keep her from being intubated is she started becoming confused, pulling her mask off, and could no longer really follow directions, and so she had to be intubated. So all of ours, I think, have not been there this week with the exception of maybe one, have been proned on the rotoprone bed. We have proned several manually waiting on the bed, but that's been a really big benefit to us as far as oxygenating the patient. It's just body position. Most of the patients that we've had have been obese, BMI is greater than 35, those that get really sick. Obesity, I think, probably has been the #1 commonality amongst all of these patients. There's some talk initially about blood type and who gets sicker according to their blood type. We had about 8 patients in the ICU the other day, and supposedly blood type A patients are 18% or 18 times more likely to get really ill with COVID, and blood type O is supposed to not really get sick as often. And everybody in our ICU was blood type O or B. We had no A's, and all of them were intubated. So I thought that was kind of an interesting little caveat, because I'm a blood type A, so that I was a little scared by that information. So I felt a little peace. But anyway, so we're proning them. That's really important. As Bert alluded to, the lungs are more compliant than they are in typical ARDS. We still are ventilating them with high PEEPs and high FiO2s. We're paralyzing most of these patients just for ventilation synchrony. They're all getting convalescent serum, or most of them who are critically ill are all getting convalescent serum, a one-time dose of that, along with remdesivir. Mike, if you'll go to the next slide. I don't know if remdesivir is on the next slide or not. Well, that's steroids. So I'll talk about steroids real fast. So let's see, about 2 weeks ago, the Europeans came out with a study on dexamethasone using 6 milligrams, either IV or PO, daily for 10 days. And they touted about a 33% decrease in mortality amongst ventilated patients and about a 25% decrease in mortality amongst those receiving oxygen. We've been using that since that study came out. That has not been our experience. If you get really critically ill with this bug and are on a ventilator and rotoproned, I don't know if there's a whole lot out there that's going to help you, even remdesivir. Can you go to the next slide there, Mike? This is convalescent serum. Again, we're doing this kind of on a one treatment dose of that. We've seen some patients that get better afterwards, and others that it's tough to notice. Our numbers haven't been just humongous yet, and so tough to really draw any correlation with that. But I don't think,
I could listen to this.
I don't think as of this point it's necessarily the cure-all. Farley can kind of talk about that more than I can, but it is something that we're doing now. Next slide. This is remdesivir. It has, in the big studies, shown to improve days from recovery from 15 to 11 days. and there was an improvement in the 14-day mortality. And the patients that we've had this go around, I think in this second wave, if you will, we've had, at least at Providence, I think now 6 deaths. All of these patients got plasma, all of them got remdesivir, all of them got dexamethasone, all of them were prone. They got everything that we had. And certainly I think it's a help, but I don't think we've found the smoking gun yet as to what's going to help these patients when they get truly critically ill.
So yeah, I'll add to that. I think at Hillcrest, we basically have migrated towards steroids in addition to convalescent plasma for all of the critically ill patients. Kind of our approach to the plasma has been if they develop ARDS, mild ARDS even, then we check them for antibodies. And if they don't have antibodies, then we're adding convalescent plasma, a one-time infusion as part of their care plan. And so it looks like both of us, Dr. Patillo, are doing very similar treatment. One thing we have not really done much of is remdesivir.
This is a good time to address 2 quick questions that have come through in regards to the pulmonologist. One is from Dr. Lashford talking about some caution with using high-flow nasal cannula over 30 liters, leading to increased aerosolization risk. Should that be cut off? And the other is regards to, are you self-proning non-intubated patients?
So I can take the, so we are self-proning non-intubated patients if they can. We have found some people are challenged from a body habitus standpoint. And again, that goes along with those who are getting more sick. What we're seeing is those that are getting sick, their BMIs, most of them are over 35. And so oftentimes we have a hard time with those. They feel better on their side than they do on their stomach. But we are attempting that. We also are attempting breathing through the nose. There's more inhaled nitric oxide that one gets when they breathe through their nose. So really trying to make the patients breathe through their nose deeply and slow their breathing down is something that we've tried as well.
And we're doing the same thing. We are using high flow in excess of 30 liters. And I think it strikes at a balance. There's a tough balance with how much do we act to care for our patients and how much do we act to care for ourselves. And I don't know that anybody's going to answer that the right way. We are taking precaution in transport of patients so that we're not exposing large areas of the hospital to aerosolization, but we'll run flow higher than 30 liters, and we are also doing self-proning. And it's quite remarkable, as you point out, Dr. Patillo, some patients can change their oxygenation by a great deal by flipping themselves over way before they get intubated. So in the final slide here, we were just touching on anticoagulation. There's been a lot in the press about this disease causing a hypercoagulable state. I don't think that's a surprise to anybody, just given the fact that the people, especially the people who get very sick, it's a highly inflammatory state. And so we have adopted a higher dosing of DVT prophylaxis. And I think even from the early stages of the disease, we've been asking ourselves, should we be fully anticoagulating? I don't think there's a solid evidence out there yet to suggest either way, but I've even heard of some strategies recently where they're checking D-dimers, and if the D-dimer is over 3,000, then they're putting people on full anticoagulation. We have not instituted that practice yet, but I think this is an area that may change as we move forward with the disease.
And that's kind of the same with us, is we have not been fully anticoagulating all of these patients. If they're on an anticoagulant already, which a lot of these patients are at baseline, we're continuing that or switching them to Lovenox if they can't take PO. Those that are critically ill and on the ventilator, we've been giving, if their kidney function allows it, we've been giving them, Lovenox 40 milligrams Q12 rather than the standard Q daily. But we have yet to systemically anticoagulate all of the COVID patients.
Right. I noticed Dr. Ritchie's got a question.
It's not a question, but it's an observation. I've obviously not been in the ICU treating these patients, but I've been following the literature as best I can. And like everybody else, I've noted the severe hypoxemia, the compliant lungs, the different way to ventilate. And I think the thing that's been most exciting to me is my reading, starting about 2 weeks ago from Ireland, when they did a lot of autopsies with a finding of just diffuse microthromboemboli. And I noticed that in New York and places, they were playing with the anticoagulation, feeling like that needed to be done. But, and this is the point I wanted to talk, there was a really interesting paper in Blood published last week, June 23rd. And it showed that the SARS virus actually gets into platelet, not via the usual ACE2 inhibitor, but rather a direct invasion of the platelets, causing very sticky platelets, and you get these rapid platelet things. And then there's been also out of Lancet, one of many now autopsy studies that are showing marked platelet thrombi everywhere. And not only in the lungs, you go to the heart, people have heart acute stoppage and they expect to see big emboli, big heart attacks. They don't. But instead they have these little bitty thromboemboli. Same thing in the brain. Up to a third of the patients, much more, either have strokes, but when you actually do autopsies in the brain, you're not seeing great big blood clots, you're seeing these little fibrin. So long story short, I think the next thing that people are going to be looking at is starting patients early on antiplatelets. Maybe make a difference here.
Thanks, Dr. Ritchie, for adding that. Will Dr. Stewart or Patil want to briefly mention the hospital surge strategies and what's our local capacity?
Go ahead, Stuart, you can start.
Yeah, sure. So, one of the most impressive things I've witnessed through our planning is actually our engineers' ability to change our hospital airflow patterns. We started out with 24 ICU beds, and we have a couple of negative pressure beds attached to those ICUs. We have other negative pressure rooms in the hospital, but we were able to re-engineer the third floor to increase the capacity, where now we currently have 12 ICU beds that are negative pressure, and with the ability to expand up greatly past that. And we have over 40 ventilators and the ability to ventilate more than that with making adaptations to non-invasive ventilators if we were in a true crisis situation. And I think I'm confident we will have the ability to take care of that many and more ICU patients. We've got a tiered system of expanding that capacity, and we're meeting it twice a day lately to discuss need for expansion, bed availability, and where hospital resources need to be put.
And ours is pretty similar. Our ICU has kind of got 3 different wings, each of 10 beds. So we have 30 ICU beds. We've partitioned off one wing for just COVID patients, and it's kind of a quote unquote clean zone, if you will. Everybody goes in there, has to wear a mask, and there's no kind of through traffic through that area. We've had to expand up to 4 East, which is a regular hospital floor, and kind of make that an unofficial step down unit, as well as taking stable floor patients. Again, I haven't been there this week, but on Monday I talked to them, some folks that work there. We had 21 inpatients, so we were having to utilize a little bit more than both of those 2 wings. But we've got room for patients. We're busier than we were the first time around. This is certainly a much larger uptick than it was initially, but we've got room for patients. And not all these patients are requiring ventilators. So I think when you hear these numbers, 260 patients a day, most of these patients aren't going to need a ventilator. Most of these patients aren't going to get real sick. And so I think we have got the capacity to ventilate those that we need to. We have access to roughly about the same number of ventilators that Baylor Scott and White does. We also have some anesthesia portable ventilators that we can use. So I think we will be okay, at least for the time being.
Thank you all.
Both of our systems are part of a larger, both hospitals are part of a larger system that can mobilize more ventilators if needed.
Perfect. At this point, we'll transition more to questions. And most of these are revolving, at least the questions that have come through, are revolving more questions around the outpatient management in terms of treatment and the return to work. And so I think first we'll start with Dr. Werner, who I've asked a little bit earlier today about some of these, but we have employers asking us to test patients to return to work. There's lots of questions about asymptomatic people. Dr. Werner, would you like to address some of these questions on the screen in front of us?
The symptomatic patient who tests negative, this is the COVID-like illness or the suspected COVID patient that Mike was talking about, and the decision whether to treat that person as if they were positive. In that case, you have the return to work issue is the same as if they were positive. A patient can return to work in general when they are released from their isolation and they're released from isolation when they've had 10 days since the onset of their symptoms, 3 days without fever and with improvement in symptoms. So if someone is symptomatic and you believe they have COVID-19, you're going to deal with them as if they do, then their return to work time is going to be when they would have been released from isolation if their test was positive. Right now, with this dramatic increase in cases, I would want to urge that we err on the side of potentially overcalling that subset of patients who you think are COVID-19 by their symptom complex, but their test is negative. That group, since ideally you put them in recommended isolation when the test was performed, that they stay in isolation as if they were positive. The next one, a patient exposed to COVID-19 patient but is asymptomatic, when can they go back to work? A person who is truly an exposure, meaning that they're a close contact to a positive person, and they're going to have been identified in that contact tracing and placed in quarantine. You get and a person in quarantine because of exposure is released from quarantine at 14 days after their last contact, and that's when they can go back to work. The safe return to work guidelines and the last question, employers wanting employees to be tested before they return to work is a problem that's out there right now. If a patient should be able to return to work if they were a case when they're released from isolation, if they were a contact when they're released from quarantine. Right now, we're trying to discourage employers from requiring testing of employees to return to work from largely the standpoint that we need to utilize those tests now for identifying active cases. So the message we're trying to put out is that kind of testing shouldn't be required by employers, but they can do it if they want, unfortunately. When can, the other issue is employers who are wanting a negative test or some sort of return to work. And my suggestion would be if your patient is trying to return to work but not able to, that adapting your normal return to work note that says this person has been released from isolation or quarantine and is safe to return to work, and hope that that satisfies their employer. The perioperative testing question and management of asymptomatic cases, the issue there is when we test an asymptomatic person and they test positive, what's happened is you've detected virus, but we have no way of knowing when that person was first had virus present and how much longer they'll have virus after that. They may be pre-symptomatic, which helps answer the question, but when they never develop symptoms, what we don't know yet is the kinetics of viral load in these asymptomatic patients. Do they continue to have replication competent virus for a shorter or longer period than people who do have symptoms? When we have a person who's asymptomatic, they're tested for whatever reason and they're positive and asymptomatic, then we consider them a positive case and they are placed in isolation. And since we don't have an onset of date of symptoms to use to base their 10-day period, we use the date of testing. Similarly, in investigating patients who do have symptoms, we use their date of onset of symptoms to determine their contagious period that extends 48 hours before their symptoms first began. And for an asymptomatic person, we use the time of testing, the date of testing as the starting point, and consider those who were in contact with them 48 hours before that as being potential close contacts.
Thank you, Dr. Werner. We'll switch over to Dr. Ritchie now, who's agreed to answer some questions about the outpatient and inpatient treatment. There's been some other questions about whether there's zinc or some other supplements which may reduce viral replication. Is anybody recommending these? And then prophylactically, potentially using aspirin in patients who've had a history of a DVT or pulmonary embolism. And then are there any changes in the recommendations with ACEs or ARBs based on some recent data? Dr. Ritchie?
Okay, I would start with the question of zinc. My gut would say that people have recommended zinc forever for colds and the like, and I've never known that they've been validated. However, I was on a Zoom conference a week or two ago with a group that included the public health physician for Dallas County, a wise old man from Southwestern, who went through a very detailed diagram of all the chemical stuff that happens when the SARS invades the cell. And long story short, he was advocating zinc. So it may be one of those things where maybe it doesn't hurt. I guess maybe I might take some, but the second question on the aspirin, as I just said, this reading that I've done just the last 2 or 3 days makes me a real believer of antiplatelets. And so aspirin obviously is an antiplatelet. And so I would certainly put myself on that immediately. Although if I develop symptomatic COVID, I'll probably add a second agent, something on the lines of clopidogrel or one of those in addition to aspirin. And then the third question again, tell me again, Bill, what was the?
It was, have there been any changes in the recommendations for ACE inhibitors and angiotensin receptor blockers?
Yeah, at least as far as I know, my reading is that the recommendation is if you're on them, don't stop. And if you're not on them, don't get on them. I'll certainly defer to anybody else who knows other than that, but that's what my reading shows.
That's what I've read too, Rod. I've read the same thing.
We have a couple more quick questions that have come in. Next one's for Dr. Harden. When do you expect that quick testing for COVID is in under 2 hours to be available to doctors in Waco who are not associated with one of the hospitals or the Family Health Center?
That's a good question. I don't know. I don't have the inside track on the different systems. I know both systems have, some are doing their outpatient testing already in-house, and another system pivoted already to use another vendor for their testing. Family Health Center is very fortunate that we had the instrument that it's called the Sophia by Quidel or Quidel that runs that test already, and we were able to get that test and at the same time that CPL stopped doing our outpatient tests, so we were able to implement that. And I imagine there's other systems who have that as well. It just requires a firmware update on their machine and then having the reagent and cartridges to run that test. So I don't know, but I do know that all sites are able to do at least testing now locally and not have to worry about the delay as much through CPL.
Perfect. At this point, we've got about 9 minutes left, and we'll open up the floor to anyone who may have any general questions or would like to follow up on any further questions which were presented earlier.
I have one question for Mike.
Sure.
In just watching TV and watching people get their little nasal swabs in the cars, it doesn't look like to me that they're getting much beyond the anterior nares. And in watching the Chinese, they're doing all oral pharyngeal swabs. And I thought the nasal pharyngeal swab was the gold standard. Are there really any differences in these various, how well you do it, or does it matter?
Yeah, I think you're exactly right. I think still nasopharyngeal is considered the gold standard. Having personally had that experience, I described it as a cross between a DNC of the sinuses and a transsphenoidal brain biopsy. It is an aggressive procedure, and I try not to tell patients too much about it before they have the test done, because it's not pleasant if it's done correctly. So I think that's still considered the gold standard. There are other specimens that have been tested, and the problem is they haven't all been validated yet. So they are testing it and using other specimens, including there is a test with a saliva test and an at-home test. I'm not sure how accurate that is yet either, but I still believe the gold standard is a nasopharyngeal specimen. That certainly would affect your sensitivity. You know, if a test is not being performed correctly, it doesn't matter if it's a strep test, a flu test, or the COVID test, if it's not being performed correctly, that greatly lowers your sensitivity in the testing as well.
That was really my point also, is that the sensitivity should go way down.
Another question just came through to me about healthcare staffing and how we're going to staff you know, if the numbers continue to increase, and in the regards to quarantining employees who may have been exposed and wearing masks. I don't know if this is much a general question to anybody, but I think, would anyone like to address that specifically about how we keep up our numbers and staffing in the community for doctors, nurses, and others?
I think I can answer both outpatient and inpatient a little bit. I just know from conversations with both hospitals that they do have plans in place to be able to address the surge, and that includes being able to have an adequate number of personnel to take care of patients. Obviously, hospital capacity is dependent on workers to take care of patients, and so that's a critical aspect of what they're watching. In the outpatient setting, I know that we have, and I know other clinics have done, other systems have done this as well, removed from certain duties and placed on other duties, including doing our COVID care and COVID testing. We've also, if the rate gets significantly high and we have a significant number of providers affected, we've considered doing rotating jobs where you're doing COVID care for a week or two, and then you go off on telemedicine for 1 to 2 weeks, which is essentially a quarantine, and then you go back to well person care, and then you move back on and transition around. That's an option. And then if, heaven forbid, we have to open up an alternate care site if both hospitals are overwhelmed, there is a plan in place to have adequate personnel to care for patients in that setting as well too.
Additional question probably for Dr. Werner. For a patient whose preoperative test for COVID came back positive, they're totally asymptomatic, and they've been required to be retested 3 weeks later. They're still asymptomatic and still remain positive. What's the guidance on directing the surgeons, and how would you handle that situation?
That's a tough one because it's not really clear what to do with those people who have persistently positive PCR tests 3 weeks and more out from their original test or onset of symptoms. It's clear that, best we can tell, in general, those folks you're unable to recover a replication competent virus from them. And the implication is that they're not contagious, but the recommendation still hasn't come down that makes them clear of all contagious risk. At that point, if they remain positive and they're tested again and still positive, then they may be those who retain viral RNA, but very unlikely to be truly contagious. But if they require surgical procedures at that point, then they should proceed with the use of PPE as if they were a recently diagnosed positive case. But it's hard to justify postponing it beyond that. Let me take a minute to make a clarification, if I would. The information sheet that I sent out regarding what to tell patients when they're being notified of COVID-19 in regard to public health issues, there's a statement there that case investigations, identification of close contacts, and contact tracing are functions performed by the epidemiology department at public health. And please do not investigate close contacts, as this diminishes reporting compliance when the patient is subsequently contacted by public health. And the point there is that delineation of exactly who's a close contact and who's not is the difference there is that the close contacts have to go into quarantine, whereas casual contacts do not. In those situations where you're deciding that this person likely has COVID-19 and recommending isolation, then you're going to recommend isolation for all of their household contacts. And then it's reasonable to allow that patient who can identify people who are obvious close contacts because they were in social situations where for an extended period of time they were in close contact for 15 minutes or more, but they can tell those folks that they're likely close contacts and should themselves be in quarantine. These recommendations that I put out here, like any guidelines or recommendations for COVID-19, are living documents because they change awfully frequently. So I wanted to make that clarification.
Perfect. And also in your email today, you did mention the contagious period being 2 days before onset of symptoms and extending throughout the period of isolation. So At
Yeah.
this point, we will complete the meeting. That we are recording this, and so it will be sent out so you can share it with others who were not able to attend the meeting. And again, like to thank our presenters for taking that time to educate us. It's a critical time for all of us, and we need to continue to work together. So please let us know if you find these meetings helpful, and thank you all for your care and service to the community. Have a good night.